Hi, and welcome to episode 280 of the Untethered Podcast. Today we have Doctors Lynda and Krystle Dean-Duru joining us. Nestled in the heart of Ashburn, Virginia, Ashburn Children's Dentistry and its sister entity, Womb to Grow Wellness, is more than just a dental practice. It's a sanctuary where children's oral health is intricately connected to their overall well-being, embodying a philosophy of integrative, functional, and holistic pediatric dentistry. At the helm of these remarkable institutions are Dr. Lynda Dean-Duru and her daughter, Dr. Krystle Dean-Duru, who together have revolutionized pediatric dental care with their unique blend of compassion, expertise, and innovative treatments. Graduating first in her class at the University of Benin Dental School in her native country, Nigeria, Dr. Lynda's dedication to holistic health is reflected in her extensive continuing education in orthodontics, dental sleep medicine, dental cranial osteopathy, and orofacial myology. She is certified, amongst others, in advanced light functionals ALF therapy, a treatment philosophy that uses brain-friendly, custom-made appliances to promote proper neurology, craniofacial development, and optimal airway function, and is a member of the prestigious Nathos Orthodontic Education Group, Masters at the World Clinical Laser Institute, Fellowship at the Academy of Laser Dentistry, and a Fellow at the United States Dental Institute. Following her own sleep apnea journey, her approach to pediatric dentistry integrates these advanced techniques to prevent sleep apnea and breastfeeding difficulties in infants. Dr. Krystle Dean-Duru, inspired by her mother's passion, followed in her footsteps. With a bachelor's degree in psychology from Columbia University and a doctorate of dental surgery from Virginia Commonwealth University, Dr. Krystle further honed her skills during her specialty pediatric residency at the Interfaith Department of Dental Medicine in Brooklyn, New York, where she served as chief resident. Her specialized continuing education training includes pediatric dental sleep medicine, airway orthodontics, and functional frenuloplasty, positioning her as a leading expert in addressing pediatric airway, sleep, and growth issues. Quick disclaimer: all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered Podcast. I am your host, Hallie. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Dr. Krystle and Dr. Lynda, welcome to the podcast.
Hello. Thank you for having us.
Yes, well, I'm excited to have you on. I know that we chatted recently on your channel on Instagram, and thank you so much for that. I was honored to be a guest, and I'm excited for you to share your wisdom with our listeners.
We're excited. We love hanging out.
Yeah. And I love so much that you are a mother-daughter team, and I would love for you to just, before we get into the nitty-gritty today, share with us, how did that come to be?
Well, we never really planned it. As a matter of fact, I thought her brother was going to be the one joining me because she always had her heart set on being a pediatric surgeon, cardiac, and I just surgeon. And I was like, okay, well, however, when they were growing up, I always took them to work with me, even when I was an associate at a different office. And so I go, okay, you're working with me, and I'll either work with me or you work at the library. There's no working at Gap or the mall or anything like that. And then suddenly one of the summers where she was already in college at Columbia, she was on summer break, and she was working in the office, and she had a really challenging kid. And I thought, oh my God, we're going to have the conversation. She's not coming back tomorrow. And so we got home, there was a conversation, but not how I expected it to be. And she was so excited because that kid, who was a special healthcare needs patient, told her that she wanted her mom to bring her back the next day so she could clean her teeth.
Aww.
I said, oh, she did? And she said, yeah, Mom, she did. I said, so how did that make you feel? Oh, Mom, you have so much fun doing this. I think I'm going to do it. I said, no. You're not doing this. You're not doing it. She said, yeah, for real. Anyway, fast forward, she finishes school and she said, so I want to be a year off so I can take time and stay with you. make sure that's what I want to do. And even at that point, I was still like, nah, just do your pediatric surgery. Let me be alone. Leave me alone. However, it did pique her interest. And yeah, she went through dental school, went through the residencies. And as she was finishing her residency, I really needed to have her back here. However, in my mind, I thought, it's best for her to go spread her wings somewhere else. And as a matter of fact, the way I describe it to the patients, I said, go make your mistake somewhere else. Then come back to our practice. So,
yeah, I knew I'd always wanted to come back because I'd seen how the practice was and what kind of, it was really innovative because I'd gone through dental school and I talked about lasers and my instructors were like, yeah, right, laser, like nobody uses lasers to fix teeth. Like, and so I was like, but I see it, I've worked it, I've assisted, I've been there. So I already knew, I said, okay, this is where I want to work. This is the kind of place, but I also wanted like the freedom to work other places and see how things are done elsewhere. I knew dentistry was my passion. I knew working with kids was my passion for sure. And so it just worked out that I took a little break. I took a little 3-year break after residency just to kind of like get my feet wet, work with other providers, like learn and like you said, make my mistakes elsewhere, I guess. I think I picked up new skills. And so, yeah, I know. And then we came back. So I always knew that this is where I was going to be, but I definitely needed some time to solidify that decision for sure.
I love that. It gives me some memories back to when I signed a contract in grad school to go work in the schools, and I never wanted to work in the schools, but it gave me a lot of really good insight and information to then leave 3 years later when my contract ended and go into private practice, and help patients in a very different way. So, I think it's all part of the journey, right? And I love that you were able to kind of circle back and now you guys work together.
Oh my goodness. Yeah. You never know how your path and how it takes you. You never know. And then all of a sudden, I always like to say is she used Jedi mind trick because she definitely wasn't like, you need to come work for me. She is just like, please don't.
Yeah, it was that takeaway. I think in sales, they call that like the takeaway. It's like you take it away and then they want it.
Robert Cialdini kind of, Yeah. I think you did a good job, Hallie.
Yeah. I love that. But I think you also pointed out that you really noticed that there was a difference in the office and how your mom practiced. And, it sounds like very innovative, maybe ahead of your time. And so I would love to know from you all, just, in what ways do you feel like even having that experience and now working together, in what ways do you feel like you may be connecting some dots that are maybe missing in other pediatric offices?
I mean, I think that's a really good, because that's really what makes this fun, challenging but fun at the same time. I think we're seeing kids starting from days old, and they're also wanting to stay even in their young adulthood, right? Some of them have kids, some of them have homes, they have businesses, and they're wanting to stay. So that as a scientist gives you an opportunity to just see your treatments, or not that you've done anything wrong, but just see what you've been learning and how that's been, utilized, and how you're treating your patients, how they've grown, who they've become, things like that, and what changes you need to make or what changes you don't have to make, and, things like that. So that's already a start of connecting the dots, but I don't know how you consider.
No, and it's important, yes, because then I get to see what we did well, what we could do differently, and it was a lot more stark for me. I'm a recovering sleep apnea patient. And when I saw pictures of me at 9 months of age, all the signs of sleep disordered breathing with it. I had that open mouth, the torticollis, the tight fist, all that tension in the bodies. And so knowing that we're seeing kids as early as 2 days old, and the mindset became different. It became even more important to learn how do we get it so that these patients do not become the me of the future. So it's like you're catching it when it's at stage 1 before it becomes sleep apnea, or before they get diagnosed with ADD, ADHD, and that you're improving their growth and understanding too. A lot of it has to do with how their faces grew. and what the neurology is as early as possible. And so getting to put those things together, I think that's what makes us a lot different from general pediatric practices, because most times when the parents come here, they've already been to several other places, and then we connect the dots for them and go, hey, what was the birth story like? What was this infant like when they were growing up? So those things that were missed when they were younger, we could put together for them and help get them back on track. So it's fun.
And
I love that.
So you already started breastfeeding support. So even the knowledge that in 2006, like we're hearing about this now, tongue tie, lip tie, but 2006, you already knew that in order to have a mom and a baby have a really good experience with just initial feeding, something that should be natural, you had to be able to release the tongue in some way, shape, or form. This is before we had all the knowledge on how to do it so completely comprehensively. But in 2006, using a laser, not the scalpel, not a diode, but using a very well, using a laser to help a child and help moms, you already did that and started mentoring other providers. And then on top of that, early intervention with orthodontics, you started doing that too, without understanding the physiologic effects. Yeah, that's what we kind of mean by when they get older, you're seeing like, yeah, you made the beautiful smiles. They don't have cavities because we're proactively preventative. Like we're not, sealants, things like that, things that we learned and we're supposed to do, but we took it seriously because we knew exactly that it's important, right? But now, as we even learn more from seeing the patients and then seeing our procedures, that we're like, okay, I know this is, because we started orthotane,
we're way
before, right? So you knew there was something, you correct the habit, you'll get a better outcome. But it was hard to put all those pieces together because the knowledge base wasn't there outside, right? Not a lot of people had their knowledge together. And then so you're just kind of like anecdotally just helping children, parents are like, what is this crazy thing we're doing? But they're doing it, and they know something's up. So that was the nascency of how we started to connect the dots. But then as we saw more patients, and then the knowledge base became even better with some of these giants that we stand on their shoulders of, right? Like, Dr. Nordstrom, all those kinds of people starting to really look into why we're doing the things that we're doing instead of us kind of not barbarically, just kind of like, just use this, try this, and well, let's release the tongue. Well, I know something that'll do something for you. Now the pieces are being put together. So I think that's been really helpful as far as, that's the fun part about connecting the dots as well. Yeah. So from long time to long time.
No, I love that. I mean, you definitely it sounds very innovative, and it sounds like you were ahead of your time, and you knew like how we need to grow a healthy face. It's not just about moving some teeth and making smiles look pretty. How do we functionally get this, orofacial complex serving the child? Like, how do we get it so that they can breathe well, they can sleep well, they can, everything else, chew and swallow and speak and everything, everything that we need to do. And so I love that. I mean, it sounds like you were connecting the dots long before the literature supported what you were doing, which I know can be really challenging.
Right.
Yeah.
Me from her. I was like, Mom, what are we doing? What's going on here? Like, that's not what I learned. And then she's just like, no. It's how it doesn't make sense the other way. Right. So,
but I remember precisely when she first joined us, and she'll come to, we'll finish the day. She'll say, Mom, you talk too much. And like,
patients, right?
The patients, because I'm trying to explain this, explain that, get it this way, because I always felt like I was failing them if they're not doing what they need to do for their children. Because I thought, I'm feeling this child, I'm not communicating to this mom, because I'm feeling, if they understood what I'm trying to tell them about their kid, they'll run and do it for them. And so she'll say, Mom, you talk too much. And I'm like, let's go. And we have other pages. No, that's what I was using. And now I'm giving lectures. This is the lecture series where patients you talk too much.
Now the tables have turned. But you know what? I always say that makes the best, practitioner or doctor or, provider. you have to be able to explain what you're doing and why you're doing it. And if you can't, you shouldn't be doing it. If you don't know why you're doing it, it can't just be, oh, I learned this in school. No.
Right.
Yeah.
Precisely.
Yeah. So you've spoken to the importance of early intervention in pediatric dentistry. Is there anything else from like an early intervention standpoint that we didn't touch on that you think would be important for our listeners to consider or know about?
The part that I don't think was stressed enough is that, okay, why does a child come to us at 2 days old? And so if they're having breastfeeding issues, because the conventional thought is wait till they're age one, to send to go to the dentist, or 6 months after their first tooth come in. However, if a child is having trouble nursing or trouble breastfeeding, which is something that should come easily for a child and come naturally, then one has to consider seeing a knowledgeable pediatric dentist during that early times, because one, they can work collaboratively with other providers to help the child get back on the breast, because not everything is a tongue tie that needs to be cut. And so it becomes important for parents and moms to understand that. And sometimes the pediatrician will say, oh, go to the ENT, or or don't go to the pediatric dentist. However, if the mom thinks about it, if something that is wrong is with the mouth, who best has more knowledge about that than a pediatric dentist? Not saying that everybody knows, but at least keep asking questions until you find somebody who at least has more knowledge about it. So it's very important, because then once that happens, to get back on the breast, working collaboratively, like we said, there's also that guidance. So that if the tongue function was impaired for whatever reason, that you want to make sure that the building blocks of the growth of the face is there, which is getting good tongue motion, and also making sure that they can breathe through their nose, because you don't want them breathing through their mouth, really. And so most of those kids will have breastfeeding issues come with open mouth posture, and that's your foundation for not good breathing. So you want to change that and retrain for that, and also continue to follow that child to help to guide them once they get to start chewing, because that helps the jaw to come forward. If the jaw comes forward, then you have more space to breathe. And so all of those are very important early intervention things that generally, of course, you don't learn that in pediatric dental training. You get to be interested and get a zillion hours of continuing education. I'd say continuous education, much like paying school fees all over again, to be able to have that knowledge. So yes, that's the part that we think is critical. Obviously, yes, getting the teeth and making sure that keeping the teeth early enough, knowing the things to do, like not sharing spoons and utensils. If the mom has, if the caregiver has a lot of cavities, because then you can reintroduce the cavity bacteria into the baby's mouth. Anyway, so many things that they can get, so many tips that they can get that has to do with growth and also preparing the jaws for the teeth and the rest of the way.
Yeah. And just to add on that early intervention, the knowledge, right? I think we talked about the being collaborative and the knowledge that the parent receives on just how the setup is supposed to be for going forward, right? That's what, for some of them, I didn't know, I should have known. That's the part that kills me. It hurts my heart, right? And to talk about our education in pediatric dentistry, the reason why we say pediatric dentistry is important, because we learn growth and development. That's literally what we learn. We just don't learn how to apply it and how to connect the dots. That's the problem, right? That's what the zillion hours of continuous education and extra. I feel like I'm in a residency, 6-year residency, right? I've been doing 2018, and I'm like still in a residency in that sense. So that continuous education is the understanding on how to connect these dots, because we did learn this. Every time I sit, I'm like, this was embryology. This was physiology. I know this stuff, right? And being able to put it together in a way that you help your patient, that's the part that wasn't taught to us. So that's for us, that stressing of that beginning portion of life if a parent had, or if a baby had a rough journey coming into this world, I mean, there's so many interventions that are used now. It's like, not to say any of that is bad. We want the baby alive, we want the baby healthy, right? But we want to be able to give the knowledge that this baby can thrive because you have this knowledge, and we've intervened in this way that's more gentle, and then it's guiding. So then when we're talking about braces, we're not talking about multiple rounds. We're not even talking about or taking teeth out,
right?
You know, and yeah. So that it's the start. That's why we talk about. That's why we said that foundation, that the nervous system too. People don't, not understanding how that relates to your entire body, your physiology, and just essentially like in this new age, this AI system starts early.
Yes.
Yeah, like Krystle moving already. All right.
Right. So that's our big thing about why we were so proactively early intervention and proactively preventative.
In talking about it. We have not seen, and we've got so many errors on our back on that, but we're not backing down. We see the kids when we're helping them, they're getting better, they're becoming more of who they were meant to be. So why would we stop?
Yeah. Well, and you said thriving, right? And one of our mottos in my private practice is taking them from surviving to thriving. And it's, we're the feeding therapists. We're the ones who are supposed to help these kids, but we're not taught this in grad school. And so for us, it's also, I think that our national organization and state licensure requires maybe somewhere between like 15-ish hours on average of continuing ed per year. And everybody I know does it at minimum, probably 75 to 100 hours per year of continuing ed, because we're just constantly taking more coursework that we feel is necessary to specialize in this arena and work with providers like yourself, where, it's just the whole thing is mind blowing. Somebody messaged me earlier today and they said, so I heard you say you do, you and your practice do consults with patients. How do you do that when you're not licensed in every state? And we said, well, it's a consult. I said, so many parents go to so many providers and they just want somebody else's eyes on the case. They want somebody to case manage their child's case for them and help them kind of sift through information and figure out like who should I go to? We're not assessing, we're not treating those out-of-state patients. Sometimes we're just looking at the case and going, hey, you know what? Trust your gut. Like, this is the next best place. And this provider you went to has the right approach. And this is the team, that you should be working with. Or, hey, reach out to this professional in your area. And it's a lot more of connecting people with the right providers who are growing faces forward and opening those airways, right? And working collaboratively than anything else. And so I love to hear when others are as obsessed with continuing education as we are, because we just feel like we didn't get this in grad school, but we have no choice.
There really isn't. You learn something, you realize I don't know enough about it. I got to learn more. I have to put the connected dots for myself. So
yeah. And then I started as a feeding therapist, right? And I was not working with infants at the time. It was more toddler on up. And then I fell into the tethered oral tissue space and really dove more into like infants. And at the same time, fell into the myo space and was like, everything just makes sense now. I was like, why? I'm like, why are we not talking about this? Like, yes, we don't do myo with like babies and toddlers, but we can apply those concepts and adapt it so that these children never need myo when they turn 4 or 5. Like, let's make sure they don't have to have it. Like, okay, if your child is at that age, that's okay. There's nothing wrong with that. But if we can get in there, like you're talking about early on, and that early intervention component, it's just so critical. And I tell parents all the time too, I'm like, going to the providers that you need to go to from the get-go at the beginning, before you ever do a procedure especially, is so critical, because we need a baseline. We need to know what everything looks like, because to your point, not every tie, or a tie appearing to be a tie, is a true tie. We might have symptoms or tension that may mimic a tie, right? And we don't know that until we take the right approach. And that all starts with going to the right providers from the beginning. So I love your early intervention approach, because it's critical.
We consider it very important, and especially because when I first started doing this, I was the first person in our area to doing tongue ties and lip ties for babies in office with lasers. And at that time, the mom that came, all we knew, okay, they have trouble latching. Okay, yeah, we tongue tie it, we cut it. We use a laser and cut it, and, things got better immediately. And 6 months later, I come in, they're not eating still. They start to get solid foods, and then I get, I don't know, breastfeeding.
Yeah, right. The surgery looked great. They were out of bed.
What's up was good.
What's up was good. What happened, but sure what has
Exactly. And as time's gone on, we've learned a lot more of how the connection is, how when they're coming through the canal, how they can get stuck around here, how the nerves can get stuck. Then the occiput area, which is the biggest nerve, and the hypoglossal nerve, which connects to the tongue. If they're not moving, then you can cut all you want. The tongue still doesn't know what to do.
Yes.
So that led to a whole different concept in the practice. So they come, if you're expecting to get cut when you come to the fragment, I'm sorry, you're in the wrong place. I usually say, look, I have the cutting laser right here in the next room is set up, but that's not what your child needs. That's not what we're going to do. And some moms were upset about that, but that's okay. Not everyone is for us. Do know that the kids that we've seen and treated differently, like getting their bodies ready, collaborating with the osteopathic physician, the neurology conscious chiropractor, the lactation people, those kids are better. I don't get to hear from. They come in, because we're continuing to follow them. They're coming and watching from afar. They close, the jaws come forward, and they're like, yes. So yeah, the idea is to get nature to take over, because the child already has the blueprint. You just need to remove the obstacles and allow nature to do its job, which means a lot less intervention as they grow older.
Yeah. Yeah, absolutely. I love that. So what do you see the future of pediatric dentistry being? Because I feel like I feel like we might agree on this. I feel like this needs to be the future, but I feel like there's so many pediatric dental offices that are just not quite there, and they don't really even know anything about growing faces forward.
Right. So what do we see the future of pediatric dentistry to be?
Our hope is that more people will embrace this and understand that they already have a foundation, and they just need to see how to apply it to the child in front of them. And so maybe adding more to the curriculum so that there's more practical uses and practical approaches to early intervention. And hopefully they'll get to see people like you, us, and other ones who are doing things early, and we can follow those children to see what their outcomes have been. So,
yeah, I agree with that. Starting off with the education of the providers themselves, that should be already the start. Because I know for me, a lot of my friends are like, I'm trying to get into this now, and I don't even know where to help them start, right? Because I took so many I don't know where to start to help them. So, having a good curriculum, which is obviously agreed upon, and learning how to interact with other providers, all of our allied health providers that we always were afraid. We don't know what's going on, who are these people? Right, the booty, when they just touch, they just look, that they're not doing the things. No, being able to interact in that way is important. But also, not everybody has to do this, right? Knowing to send to somebody, right? And if you want to be more I'll call it urgent care dentistry, it's still needed, right? That's still very, very much needed, but also knowing how to recognize, that should be the minimum. So that should be the soonest future that should happen. Knowing how to know when something's wrong and say, something's wrong, Mom, we need to have you see, right? But I think obviously access is difficult. So being able to educate those kinds of providers to start looking at the face, looking at the function, looking at the child that's sitting in your chair, it's important. They're literally not just coming in for this. They're coming in, their eyes are drooping, their mouth open, they're miserable, or they're very anxious. Not everybody is really that afraid of the dentist like that. They're not afraid of the dentist because they're afraid of the dentist. They're afraid of their bodies in the dental chair. All right. They don't have as much resource for themselves let alone somebody else in their airway space. So that in and of itself is the hint. It's not a, oh, they're just afraid. I was afraid. No, why were you afraid? What was the problem? Like asking more questions. We need more time. We can't shuttle in, shuttle out kids in the dental office either. So that's the future of dental care is a little bit more boutique. It's a little bit more like, because we see them so much more often,
Yeah.
We're seeing them more often. We have to be able to spend more time, and they start to know you. You start to know them. There's certain things you can't deny. At least, even if they don't follow through, they know, first of all, we have it all the time. Oh, yeah. Then a couple years later, it's like, what was the thing you were discussing? And that's just meeting them where they are, to be honest. They need to have a baseline. They need to know that my doctor is knowledgeable. They know this stuff. I'm not ready now for myself, but they know this stuff. And I'm going to go when I can, right? And our motto is like, the earlier the better, but it's never too late, right? So I think that's what the future is. The future is more better education for our providers, learning how to collaborate, and that just being able to really know the signs, see the signs, and identify and take more time with and refer. Just refer. It's okay. You don't have to be. It would be nice to even learn some habit appliances and things like that, but just know how to refer. Don't say it doesn't exist. Don't say it's too much, or it's a fad, or they'll grow out of it.
Yes.
Yeah. I learned that in dental school when they said lasers or fad. From then on, I can't listen to this.
You're like, I've turned you off. We're done here.
Certificate. I love my dental school. I went to BC. I love it. I was trained very well. I love my residency, but at the same time, there are limitations.
Yeah. 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 No. And you highlighted several times, like, it sounds like there's a need for more maybe a screening or some sort that is more standardized, that all dentists all dentists could adopt. Making up words now, to use when they're working, while the teeth are being cleaned by the dental hygienist. They can be looking in the mouth and checking off some boxes in their mind. And we created like a fast myo screening tool it's more geared towards like older kids and adults. It's not really, so it is airway focused and all of that. But at the same time, I feel like even a simpler version for dentists that could be used across pediatric offices, where you're just kind of like, every single time you see that child, whether it's every 6 months or however frequently you see them, it just kind of tips you off to know, do I need to refer? And then I love how you also spoke about the referral process and kind of collaborating, and who should we be collaborating with? Because even like within my membership, we get this all the time. Like, well, what do these people do? And we recently created some resources to spell out for like myofunctional therapists, mostly like SLP, OT, RDH, some dentists were like, hey, these are the collaborative providers you typically are looking to work with. Here's what their roles typically are, even in our space, at least those who are specialized in the myo airway, forward growth, facial growth arena. And then we are creating one just for like body work now, so that we can list out the different types of providers. Because that's like you were saying, it's like, it's not just voodoo. Like, I can't tell you how it all works. Some of them have been on the podcast. So they can tell you much better than I.
Exactly. Right.
But it works. Right. And so it's like when we all come together with our respective specialties and we're collaborating and figuring out what each patient needs individually, like we see like you were talking about before, you were saying, we see the differences it makes. Like, I don't need a research paper that's going to come out 17 years from now to prove that what we're doing is working, because we see it before our eyes.
You mentioned something too that's on my mind. It's that I was one of those, like, I need the science. I need to see that this and that, the random. And when you realize what healthcare is it's not the science. I mean, it's science, but it's life science. Right. So you just said it, the research just come out years later. That's number one. Number two, there's certain sciences you cannot do experiments on.
Right.
Human.
Right.
And so there has to be a feeling or a vocation when a doctor goes in to be a doctor. Yeah. There has to be some kind of vocation in trying to heal, not just following certain recipes, right?
Because you're a healer. You're a healer, and that means that you've got certain gifts within you to be able to put things together, to see critical. Yeah, you have some critical thinking thoughts. It's just like when people say, oh, we use a non-surgical laser, the baby laser therapy, and then they say, I've looked everywhere. I don't see anything published on baby laser or oral laser except for the people who are doing it. And I go, okay, if you understand laser physics, and if you understand the literature that's already in on photobiomodulation, then you can see how that's an extension of that. Some very smart guy that in the name Dr. Nordstrom, Derek Nordstrom, has figured out that if you use the intensity of the 1064 nanometer wavelength laser that is already available, that does penetrate deeper into the skin layer where the nerves are, the mitochondria, all of that, the fascia is, and that fascia can get frozen, the hyaluronic acid can get frozen, and when you apply lasers to it, it can decrease and allow the flow. You just applied it in a certain manner. Now you're able to decrease the fascial flow or increase fascial flow in the head and neck area. And you see it all the time. After some of the pains, they come, they have this much discomfort on the sublingual fascia, and they go, oh my God. And you put the light on and come like, can you try it again? There's what did you just do? Magic. And it's not magic. It's just that we allow flow, we allow motion, and life is motion. So it's being able to put together the science that is already there, the technology that's already there, and then figuring out how can I better use it to help patients more. So, and if that helps reduce the amount of ties that people get cut, yes.
Yeah. Well, that's invasive. Amazing. Yeah,
exactly. Work with a cranial osteopathy, and then she says, "Oh my goodness, we could be working together." And I just start the light here, and she's at the feet. She goes, "Oh, the feet just felt like mushy." Yeah. For me, when I first heard it, I was like, "Oh my God, okay." What? And you grab and you land it once on your skin, and then you're putting the light there. Then I have to remind myself. All the laser education I've got, okay, I understand it. The photons are now acting on the cells. The light energy is penetrating deep. That makes sense, right? Being able to utilize the skills you have and put knowledge together. I'm sure within the next 5-10 years, that's going to be what, if you're not using it, is like, what kind of provider are you, right? Because even now they're using it in transcranial therapy for TBI, traumatic brain injury, and for Parkinson's. Wow. Same technology.
Yeah.
So why are we so resistant in being able to use it in the head and neck region, which is the most important area? Yeah. So we're dealing with the craniofacial respiratory complex, aka Dr. Voice.
Yeah. Yeah, I have so many thoughts on this. One, they've just popped in my brain. I was having this conversation with somebody last week, and I said, well, it's actually, I've heard it's pretty common that, more elder patients who need, not dental implants, but who need dentures, thank you, will get cheek ties and lip ties sometimes released because it impacts their ability to wear dentures. And someone said to me, what? And I said, yeah, so, if these children are struggling with feeding and with breathing, with sleeping, but it's okay to remove them for a denture. Like, why, what's the disconnect here? And someone was like, you make a valid point. And I'm like, see, these are the things that people aren't talking about. The other thing too, as you mentioned, like it, as we kind of talked about a few times now, is it takes about 17 years for the research to catch up. And one of the things that I don't love our national organization, ASHA, but one of the things I do appreciate about them is that, they do highlight the evidence-based practice triangle. And in that triangle, they focus on client perspective, clinical expertise, equally with the external scientific evidence. And I think that, one of the biggest issues, especially in my space too, is a lot of the evidence that supports the work that we're doing, it exists, but you have to know where to source it from, or you have to be smart enough to pull it together from different sources to make sense of what we're doing, which is what you beautifully explained with, Dr. Nordstrom's approach and using the laser. And there is a lot more evidence than I think that we give credit for. But at the same time, even if there wasn't, we still have the clinical expertise and the patient perspective experiences that are very real. And that's 2/3 of that triangle. So why are we dismissing that so frequently? Yeah. Yeah.
Okay.
Yeah.
Yeah. And that's the future of dentistry. And I think, or in medicine, right? I think that's what COVID did for a lot of people. They stopped because they couldn't go out. They were like, well, let me research what actually is happening. They did their own research. I'm not saying that they knew how to synthesize this information, the common person, because it does take some schooling to understand even how to know what you're looking at.
Yeah.
But it piqued their interest to say, I need to figure out my body. I need to understand. And to me, that's the least that a patient should be able to do. They can't just they shouldn't blindly just go to a provider. They should have an idea of what they're looking for, why they're looking for it, what's ailing them, when it started, things like that to help us co-collaborate in their healing. So to me, that's where the future of dentistry is, or just healthcare in general. Yeah. And medicine.
3.0.
Yeah.
And 3.0.
Yeah.
3.0. Yes. Yes. It needs a complete overhaul. So yes, absolutely. So, okay. So if you were a mom out there who's kind of like, okay, what do I do next? And maybe, we can even talk about this differently. A mom who is pregnant or who is looking to get pregnant versus like a mom who's already got a baby in her lap. Do you have different tips or suggestions for what they should look for, where they should go?
Well, let's start with the one who's planning to be pregnant. And I'm so happy for you because you have the opportunity to create the healthiest baby you can. And so you start with finding out for yourself, what's your sleep like? How are you breathing? Are you grinding? Are you snoring? And those sort of things. And if you are, look for help for that. And so the best time to feed a baby is usually 2 years before you actually plan on having them or before you get pregnant with them. So you have the opportunity to at least change some of your nutrition, change your breathing and sleeping patterns, and get more whole foods as well to prepare for that baby. Now that you're now pregnant with a baby, then you also have to check your breathing. Are you snoring? Yes, there's going to be some impact because now you're carrying another human being. However, it shouldn't be to the fact that where you're snoring, you wake up, you're tired, you're tossing and turning, because that usually meant that there was something in there before the baby starts coming. So you can still get help. As a matter of fact, I think there's a county or someplace in the West Coast that intentionally put women on the 3rd trimester on a CPAP to help them with their oxygenation, because the way the womb is or the condition in the womb determines how well that baby is going to be. Because mind you, they're practicing all the things that they're swallowing as they're inside, preparing themselves for the outside world. So if they're not getting good oxygenation, then the neurology, the electricity is not going to be there enough for them to do all the things they need to do. So they will already start compensating while they're in the belly. And the compensation is not life. That's just surviving. You want your baby to thrive. So do your best. Keep your nutrition, get whole foods as much as possible. Get good breathing techniques. If it's yoga, Pilates, wherever it is that you can, wherever it is that you can, look at y'all people. Whatever it is that you can do to get your mind and soul and body ready, that will be helpful for the child. Now, when the baby comes, and obviously that's a joyful moment, everybody's happy. Now that baby should intuitively come and crawl up and find the boo and latch on and move up easily. And it should be a very beautiful experience for both of you. There should not be pain with it. Okay, there's some discomfort, maybe you're both trying to figure it out, but it should not be painful such that when my sister-in-law was in the hospital, she said when it's time to feed the baby, she didn't want to. She wanted the hospital to take the baby. It should not be that kind of discomfort for whatever reasons. If it is, keep asking questions, keep looking for the answers until someone helps you figure it out. So I don't know, I'm talking.
No, this is, I was this mom, so I'm sitting here going, yes, continue. This is so helpful.
Yeah, they'll keep asking and they tell you, oh, they're going to grow out of it or just get to a bottle. That's the most unkind thing for any provider to tell a mom, oh, just get to the bottle anyway. So they want to breastfeed. You mess with their mind. This is something that should be easy for them to do naturally. If they're not able to, if it's not happening, help them find answers. Don't just throw the bottle at them. It's not the same. Okay, but sometimes when you can or have to use the bottle, that's okay. We welcome that. But then let's figure out what kind of bottle should we use that will best mimic how nature meant for this tongue to function and help to develop the face and the jaws. So I think what I'm getting to is don't stop looking for answers. Oh, keep asking, because you're going to find someone who's going to help you figure out how to get your baby thriving.
And also, if the baby came into the world a little bit, if it was C-section, if it was baby was in the canal for too long, so the journey was a little bit rough, a little bit difficult. Take that into effect too. And always keep that in mind. That some parents are like, well, they came out. I'm so glad they're surviving. They came out, right? But the way that they came out is going to affect how their nervous system develops, how their body and how their jaws develop too. So eating and how they came out. So that's very important. Yeah. So that's the first thing. And then as they continue to grow, definitely you want to find a knowledgeable provider to be able to help you start guiding. Because by the first 1,000 days is probably the important part and most critical part of a child's development. So that's up until about 3 years old. And you would think they've lived they're intelligent. They've lived a whole life.
Oh, yes.
We are, so it's so important that we nurture that. And so that's a big thing.
Very important. I'm glad that you brought that up, because the brain's growing the most between when they're born and 90 days of age. And so you want the most. I didn't know some of these things when they were growing up. I'm feeling like I need to let these moms know, help your child.
Yeah.
That we turned out badly. Yeah. When you think about it, it's what energy, what are you having to use? What is being, it's like robbing Peter to pay Paul, like would I have anxiety, like those kinds of things, or would I be able to, be as resilient, right? So am I having to take up my resiliency like bank to be well, be who I am? Because I grew up and I had all that. I sucked my thumb. I had, had tongue-tied lips. I'm in treatment now, and I can already see a difference because I did get braces. I had straight teeth, but things were wrong. I had TMD issues, so getting on analysis, and that resolved being able to do a lot of myofunctional therapy. Like I could see my face being relaxed, So there's so many things that you're pinpointing when you're doing symptom management as an adult. Yeah. Meanwhile, when you were younger, we could have been guided. You wouldn't even. That's probably the hard part, because some parents are like, I don't see any problem, but you have to look at you, Grandma. You okay? Like that. You almost have to, and then they start remembering, like, oh yeah, I did have to do that. They remember not toddlerhood, but like when they were in school. Yeah, I did have I was in braces for like 10 years.
Or you start telling them now, like, all these different myo symptoms, and they're like, what? That's related? We're like, that's absolutely related. You've got a whole myofunctional disorder going on, and this could have been prevented. Do you want this for your kid? I mean,
Yeah, every parent knows what they themselves on their own is dealing with. And that's robbing away this joy, and it's robbing away, and you're just chronically ill. You don't know why. It's robbing joy, and all kinds of things you have to. I'm not saying it's all dental related, but this is a very important.
I mean, the window to health is your mouth. So,
yeah. The more I hear it, some of my doctor friends like, everything is airway. You always talking about. It's like, I can't help it, right? Like everything deals with like your entire system and how you breathe.
Yeah.
So I can't help but I'm looking, you look at your friends and you're just like, well,
I was having this conversation on Saturday. I was visiting with some friends up in like close to like Maryland, Delaware area. And I looked at one of the kids and I was like, she has got the most beautiful smile. She's got little spacing between all her teeth. It fills her mouth. I was like, this is so uncommon. This is just, and every time I look at her, I'm like, so captivating because it's just not what you typically see. And I was telling my friend who's actually a nurse practitioner, and I was like, her mouth is just phenomenal. Like, I want you to recognize like how good and how rare this is. And, my other friend was like, well, what is it supposed to be like, looking at her kids? And I was like, oh boy, here we go.
Right.
I was like, well,
have spaces in between their baby teeth.
Yeah.
Get a nickel between each one of them.
Yes.
And you should be able to see like almost all of the top and almost all of the bottom. And they come through like that. They have.
My second one had such a deep bite. And, it was interesting because I was that mom who had obstructive sleep apnea in pregnancy, but like maybe some more mild sleep disorder breathing beforehand. And I didn't put on a ton of weight or anything, but my nose, I developed like a bump in my nose. I already had a deviated septum, and so that did not help. And then Lily, my oldest, now she's about to turn 9. She was the one with the tongue and lip tie that I didn't know about until she was 24 months old, that I discovered when I was taking my myo course. And she was hard to feed. And I went to lactation and, IBCLC is supposed to be tot savvy and all the things. And I was told, look, she's feeding beautifully. And then it's like you take your car to the shop and, you end up, it doesn't make the noise. You go home and all of a sudden it starts like sputtering again. I'm like, that was my child. And anyways, she breastfed 13 months and it was painful. Like there were times where I could not look her in the face because I was turning my head so she wouldn't see me grimace, which I'm going, which is a whole catch-22 for me because as a feeding therapist, I'm like, you're supposed to make eye contact with your child. This is supposed to be enjoyable. And here I am like looking away because I don't want her to see this like, awful expression on my face because this hurts. And I was also told in the hospital, oh, it's going to hurt for a few weeks because you're a new breastfeeding mom. And then I had my second child who was released at 5 days of life, her upper lip and her tongue. And with all the appropriate interventions surrounding it, it was pretty early. And, I think in some cases I would have waited a little bit longer, but night and day difference. Fed so differently. And then we did a lot of body work throughout the first year of life because she also dragged one of her legs behind her when she started moving around. But, both these kids were in early expansion. They've now both had 2 rounds of expansion. One is 6 and one is turning 9. And they're going to go into maybe a 3rd round. And we've had various providers because we moved, right? But I've been of the, I trust my airway providers and I'm like, whatever you think they need, let's do it. I'm like, I know their teeth will be straight if we have the space for it. So I'm less concerned about the straightness of their teeth. I want to make sure that their teeth will fall out. I want to make sure that because they were delayed and they started losing teeth as soon as they had the space to lose the teeth.
Yeah.
And I was talking to one of my friends about that too this weekend where she was like, oh, well, I think her 6-year-old or 7-year-old has only lost like 1 or 2 teeth. And I said, well, my girls were delayed until their expansion started to kick in and then like teeth just started falling out of their mouth. Like things could grow in. It had space to happen. Yeah.
Don't understand too.
Yeah.
First foundation for if there's no real estate and you've got big honking, we saw that yesterday, huge teeth coming in. Baby teeth are gonna be like, I don't want to go anywhere.
I mean, it was amazing. Like Lily had a row of shark teeth. Yeah, shark teeth are her lower central incisors, just grew in right behind the teeth. And we went to one ortho who was supposed to be airway centric here in Boca, and he did a beautiful examination at the end. Was like, well, she's already been in some expansion. I don't want to tire her out. And I was like, she's turning 6. Like, this is a normal, like a typical age for ortho. Why are we talking about tiring her out? She's a fantastic patient. And he said, well, let's wait like 6 months. I was like, what is 6 months going to do? Like, we're ready now. And he goes, well, why don't we pull out those lower 2 teeth? I was like, well, your dentist friend across the hall just told us not to do that and to give it 6 months to see if they come out on their own because, we do have some teeth there. They're not fully grown in, but maybe it will resorb the root. Maybe we'll naturally lose those front 2 teeth. So I don't want to pull those teeth out. That just seems like unnecessary trauma right now. But expansion probably could help speed that up too. Yeah? No? I don't know. I mean, I'm not the ortho or the dentist here, but I'm just going based on work with patients and collaborating with colleagues and, the research. There is research to support this now. So now we drive an hour south to go to somebody else.
It's hard. I'll say for my provider friends, because it may not, the ones that don't believe, but they may not. For us, again, hours in the back, which we're okay with because we know what it is. But I think part of it too is when he said stuff about tiring the patient out, we heard that as well. Patients don't want to wear the apply and compliant. That is something you take into effect, but it's a choice, right? You have to. We're running against time.
Yeah.
So maybe we take a break before Invisalign, when it's time to do the alignment. Right. This part, the foundational building, there really is no option.
Yeah. Yeah.
Why I feel, this is what was learned in school, and some of my provider friends, they probably experienced it in their clinic, but not knowing maybe the foundation and the principle of why it needs to be done to be able to reorient their mindsets about, the treatment and choices, because there's really no time.
Yeah. Well, and I had the most incredible before and after CBCT images of Lily from having her ALF appliance when we were still in Maryland.
She had an ALF. No.
She had an ALF, and it was during COVID. So it got put in, and then COVID happened. And so we really didn't do any body work because everything was shut down. And so, but I think she got it put in around August. So right after she turned 4. And she had kissing tonsils. And within 3 months, she was still in school at that point, right? Pre-COVID, fall of 2019, she had beautifully sized tonsils.
Okay.
She was not getting, her tonsils shrunk down to 1. She was no longer getting sick in cold and flu season. This was again, pre-COVID. And then her sinus, her cavities, they just opened up. And we had this year apart CBCT scan that we did. And my friend is very cautious. She doesn't like to just do the CBCT. She's like, it's we don't need to prove it to anybody. I was like, no, I want this. I know it's for exposing her to a little bit more radiation, but I'm I think this is important, information, 1, for me to have, but 2, we can educate people with this too. And Lily's the best patient. So, we have this just beautiful, and I share it with people because I'm look what expansion does. And this was slow expansion, right? And then my older one, who had croup 9 times in 1 year as a 3-year-old, we put her into a rapid palatal expander with a forward growth component because she was in an airway crisis, and we didn't have that time for the slow maxillary expansion to kind of occur. We kind of needed a little bit more faster paced expansion for her. So the dentist here suggested going into that versus the ALF as step 1. And I was like, listen, you're the expert, you tell me. And since then, I've seen more research come out on all these, approaches. And I'm just I'm so grateful because it's made them healthier. Their jaws have grown. They're not done growing yet. And I'm I will do whatever we need to do to make sure they have healthy airways.
And you make a really good point. I love that. I love that that's happened for your girls, because the success and the way we measure success is no longer how many millimeters or, where the teeth are sitting. No, it's actually, are they healthy? Are they having these health, growth, and is their development going in the way that it's supposed to go? Those are the measurements of the success that we have to, as providers, dental providers, kind of reorient our mindsets. We really do have to, because that's really what matters at this time. That's why early intervention matters, because that foundation and the building blocks that we're doing right now, that it's going to show itself in those teenage years when it's not just hormones where they're having this anxiety or they're being, ornery and really just annoying, that is, they still will be, but not to the point where they can't express themselves to you, right?
Yeah.
They will be.
They'll have more buckets of energy and to manage all of that angst that comes with those changes, right? I talk to parents sometimes about buckets of energy. Your child has 10 buckets of energy when they wake up in the morning. And if they have an airway crisis going on, they're down to 3. How are we going to divide up those 3 buckets over the course of the entire day? They're probably gone by breakfast, and now you're sending them to school. Versus a child who has an open airway uses 1 bucket by breakfast. They use another bucket middle of the morning. They use another bucket by lunch. And we've only used 3 halfway through their day. they've got lots of energy left. And so just using like examples like that with parents were kind of go, oh, that makes a lot of sense.
That's part of how to learn, like collaborating with other providers, because you guys know how to kind of break it down in a way that is doable, even for me as a person.
Yeah.
It just makes more sense, and that's what's helpful in educating the parent.
Yeah.
They have the choices. They can make the choices on that.
Yeah, absolutely. Well, this has been amazing. Are there any last thoughts, comments that you want to add before we start to wrap?
Yeah. Any last comment?
Oh, well, I think I wanted to go back to the comment when you talked about the ALF appliance, the ALF appliance, and some parents, some people, especially some providers, have thought of it as an extend. And I want to clarify that it is not an expand. Mm-hmm. It is what biomagnetic, meaning the way that it was developed, it's helped with the cranium to support it and have the tongue be able to do the job that it naturally needs to do. So it does take time, depending on the child, depending on what their body's ability is, how much electricity, meaning how well their cranial nerves and their neurology is connected to help them be their best self. So when they say, oh, it pushed the teeth here, it pushed the teeth there, that's because the people, if you're using it as an expander, it will push the teeth. That's not what it's supposed to do. But you will get the room, you will make a good foundation, and the teeth will come in close to where they're supposed to be. And that's really is important because many people have talked about it in that manner. And so providers go, you cannot take one class and think you know about how to use the appliance. It's a multitude of steps, multitude of classes, multitude of understanding, and also mindset change, because as dentists, we want to see something change right away, and we want to do something with our hands. You almost literally have to sit there and watch nature do its magic, right?
Yeah.
And, well, of course, with the intervention, the body and all of that. For us, we always incorporate the non-surgical ways, like in the fascia moving. We have an osteopath we work with, some chiropractors, and we work with a team that helps the whole body to integrate so that your body can help you be its best self, because nature has already got you covered. You just need to remove the interference.
Well, I think that was a great last step.
Yeah. I love that.
Sure, dental care. Future and back to nature. Yeah, that counts. But
I love that. Well, thank you both so much, Dr. Krystle and Dr. Lynda, for joining me today. This has been amazing, and I know our listeners are really going to love this entire chat.
Thank you so much. It's so good to see you again. Till the weather turns out a bit.
Thank you.
Thank you so much. Awesome.
Thanks for listening to this podcast. If you found value in this episode and want to hear more of these MyoTots airway and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at HallieBalkin.com or pop over to @HallieBalkin on Instagram to get all the latest updates.